Good evening, everyone. A warm welcome to ISU USA Smart Learning class for the residents. And as you are aware, that today's topic is bladder cancer. So let me just first invite Honorary Secretary USA, Dr. Lakshmanu, for the opening comments. And then we'll introduce the speakers, Dr. Keval and Dr. Ashwin. And then we'll carry on with the proceedings. Over to you, Dr. Lakshman.
Yeah, thank you, Dr. Arun Chawla, for this brief yet pleasant opportunity to address those who have logged in. And I have no doubt that this is going to be one another wonderful effort by the Indian School of Urology in educating our trainee members. Now, there is a beautiful definition of NMIBC. It is regarded as a polychronotopical malignant diathesis. In space and time, it has a tendency to recur. And it is also regarded as the most expensive cancer because the follow-up can be very long drawn out. So today we have two wonderful speakers who will be introduced shortly, and the learning objectives I have gone through. I'm sure that those who have logged in will have a great time in learning about this wonderful entity, which again, I would say that there is no, if there is one disease, a malignant disease, which cannot do away with the cystoscope, it is bladder cancer. So therefore, it is entirely the urologist's prerogative. So I wish you all a great time. And thank you, Ashwin and Keval. I think I'm sure that you will do a great job. Over to the chairman of Indian School of Urology. Thank you for this opportunity.
Thank you, sir. Now it's a privilege for me to introduce the faculty of today's program. And today's faculty doesn't need any formal introduction. They have been to our programs a number of times. When I have asked their CV, I think the CV which they have sent is full of so many accomplishments, so many awards and so many honors. But what I know is they are young bright stars of our Urology Society of India. Both have very keen interest of in uro-oncology. Dr. Keval Patel is from Ahmedabad and Dr. Ashwin is from Mumbai. They have many publications and have many presentations at different zonal, national and international levels. And indeed, we are delighted to have both of them for today's program. Regarding the script of today's program, as you are aware, our faculty will be taking you towards the TURBT of a bladder mass once elected, and they will give you the indications where you have to do the restage TURBT, and then how to follow with the adjuvant treatment, and in which case you can go for early cystectomy. For the second half, regarding muscle-invasive bladder cancer, they will be talking about the role of radical cystectomy and the various neoadjuvant and adjuvant chemotherapy. And today's webinar will be very useful for the agent because you get this case in your practical in the form of Watson, short case or a long case, if it's hematuria with bladder cancer. And also, the way they will be covering the recent advances, it will be of interest for the theory topics also. With this, I hand over to Dr. Keval and Dr. Ashwin for carry on the further proceedings, and I'll come in the end for closing the session. Over to both of you.
Thank you, sir.
Thank you, sir. Thank you so much for the introduction. I think, Keval, you can start off.
Yeah, definitely. Definitely. First of all, let me thank the all the office bearers of the Urology Society of India and the Indian School of Urology for considering us worthy to be presenting or presenting our views and what is literature for the common disease today. And I especially thank Dr. Chawla sir for having faith in me. And I must say, I am given by Dr. Prabhu sir. I mean, I have not found the definition anywhere in the book. So not let us start with our talk. And first, let me show my screen.
Keval, you can share the screen, I think. We are not
Yes,
seeing
sir.
you.
Yeah, I'm now it's visible, sir.
Not yet. Yeah, you can make it a
Kemal
slideshow.
seen, yes, it's visible
Now?
now. Just make it into slideshow.
Yeah, just I'm just now. Yeah, I hope it's visible now.
No, I think you have been somewhere in the middle of presentation. Can you come from the beginning?
Now, sir. Now.
No, I don't know.
Yeah,
The slide which is seen to us is TURBT energy source. Maybe you can start off as in go back on the presentation.
Yeah, you're good to go now.
No, sir, but I can. Okay, I hope the first slide is seen. No, non-muscle invasive bladder cancer.
Yes, Kemal. You can.
Okay. So now let us start. Let me start my talk today on a very common and relevant topic, that is non-muscle invasive bladder cancer, which most of our urologists face in day-to-day practice. So my talk today will be revolving around the common areas or common topics of the non-muscle invasive bladder cancer, and I may miss some clinical topics of NMIBC, but I am sure I have seen presentation of Dr. Ashwin, my colleague, who will be covering those, like investigation part and other things. So they are both common for non-muscle as well as muscle invasive bladder cancer. So I'll not be going in details of those. I'll be covering today topics relevant to TURBT, like what are the techniques, how do you report a TURBT, what is an adequate TURBT, what are the newer methods of visualization of bladder tumor while performing a TURBT. I'll also introduce everyone to risk stratification system, which is already there, but then I like to clarify it. Secondly, I'll be discussing the ins and outs of intravesical therapy, both chemo and BCG. And finally, what is the role, or what are the indications of radical cystectomy in non-muscle invasive bladder cancer? So when we are done with the diagnosis of a bladder tumor, the first step in the management of a bladder cancer is transurethral resection of bladder tumor. So it provides both therapeutic as well as diagnostic advantage in management of the disease. So the technique in which the TURBT can be done have been described in two ways. The first is it can be either in a piecemeal resection, or secondly an en bloc resection. So in piecemeal resection, we first remove the exophytic part or maybe endophytic part into the bladder, then the bladder wall, and sequentially last the edges of the bladder wall. This can be done using diathermy loop, either monopolar or bipolar loop, or thulmium lasers has also been described. And if I talk of en bloc resection, all the tumor, like all the fractions, are removed in a single cut. So again, it can be done using a diathermy, that is a monopolar, bipolar, or a thulmium laser, or a holmium, or a KTP green light laser. All these techniques, all these energy sources have been described in literature. Well, en bloc resection has an advantage of increasing the accuracy of T1 staging and also the possibility of substaging. Again, it has an advantage of decreasing potential complications of a piecemeal resection, that is bladder perforation, because everything is in front of our vision. We look at the techniques, that is piecemeal versus en bloc resection. No increase in rate of detrusal muscle retrieval has been found out in a recent systematic review and meta-analysis. Now, as we know, whenever especially the tumor is located at the lateral wall, there are high chances of bladder wall perforation due to obturator jerk when we use a monopolar current. So to avoid that, a bipolar current was introduced, and the proposed advantages of bipolar, which was speculated, are it reduces the complications, risk of complications, for example, perforation. It produces better specimen. Well, various studies have found that bipolar TUR leads to lower fall in hemoglobin and shorter hospital stays. It also has less thermal artifact in the specimen. However, if we compare for safety and efficacy, no major benefits have been noted. So, overall review of the literature regarding both the technique, till now, the results are controversial to favor one technique over the other. Now, a very important part of doing TURBT, which we all usually miss, is reporting the findings of TURBT. Why is it important? Because the findings, reporting of the findings will lead to eventually risk stratify the patient and suggest a good management strategy for the patient. So whenever you do a TURBT, you should try to assess the risk of the disease. That is the number of lesion, the size of the lesion, the location, the architecture. It is sessile, papillary, nodular, or mixed, or a flat lesion. Whether there is absence or presence of a carcinoma in situ, whether the tumor is a recurrent or primary tumor. The clinical stage should also be assessed using a bimanual clinical examination. The adequacy of resection on table can be assessed using a visual complete resection and visual of skeletal muscle at the base of the resection. Presence of tumor in the distal ureter should also be noted, and any complication in the form of obturator jerk, whether it led to perforation or not, should also be noted. Now, as we talk adequacy of resection in a TURBT, it's very important. Why? First of all, the surrogate marker for adequacy of a TUR resection is the presence of detrusal muscle, especially if the tumor is T1. The absence of detrusal muscle in the specimen usually will lead to a high risk of residual disease, high risk of early recurrence, and lastly, tumor understaging. So, the noting of detrusal muscles presence or not, the adequacy of TURBT, whether it's adequate or not, is very important, and it is indicated by the presence of detrusal muscle. Now, one more clinical scenario which we commonly face in our practice is that while we are doing TURBT, we come up with an accidental finding of bladder tumor. Usually, especially when the median lobe is large and the radiologist is confused and the tumor is small that we are not going CT. So what should be done in those situations? The guidelines have a very clear-cut view and idea of what should be done in those cases. So there is theoretical disadvantage always of seedling of tumor cells in the prostatic stroma. But however, the literature says that simultaneous TURP with TURBT can be done if the tumor is small, papillary, and unifocal. And it has also been found that after doing TURP with TURBT, there is no increase in risk of tumor recurrence or progression. Now what are random biopsies and in which cases it should be done? So again, this is a very common topic for while doing a TURBT. Well, when should be a random biopsy? Random biopsies are biopsies which are taken from areas other than the visible tumors. So where it is indicated in cases of presence of velvet-like radish area, which usually may be confused with an inflammation. It may not look like a tumor. Secondly, it is indicated if the cytology is positive, but the mucosa throughout looks normal. Now, what are the sites? If the abnormal looking areas are present, like velvety reddish areas I told, those areas should especially biopsy and be noted and marked, the site marked in the report or findings. If normal looking mucosa is there, biopsies 1 or 2 from each of these areas like trigone, bladder dome, right and left lateral wall, anterior and posterior bladder wall should be done. They should be sent separately for histopathological examination. So many times we find that the tumor is very much near to bladder neck or extends to prostatic urethra. Sometimes we are also confused The indications of prostatic tissue biopsy, maybe prostatic urethral biopsy while doing TURBT. So if the tumor is located at the trigone or the bladder neck, you should always do a prostatic urethral biopsy. If you have areas of presence of bladder carcinoma in situ, like velvety areas, then you should take
Keval, are you there online?
Sir,
Kiran
the
madam?
cable has got
Yeah, just wait for a few seconds. Let him join, okay?
Kiranji, I've sent my presentation to you just in case if you can download it. I'm just trying to open my laptop now. Can you just
Sure,
download
sir,
it just
sure.
in case Keval is not able to log in? I've sent it on Navneet's email. Yes. So that just in case.
Okay, sir.
Okay. I'll
Okay.
keep my laptop open in another 2 minutes. I'll be able to log in. Yeah. Through laptop.
Uh, Dr. Ashwin, do you want to start? I can put in your presentation.
Yeah, that will be great.
Okay, sir.
All right. I'll just tell you to move the slides if possible. Yeah. Okay. Yeah. You can make it full screen. Yeah. So I think Keval will be joining shortly. Will in the meantime, we'll continue with the MIBC discussion. Yeah. So bladder cancer is a seven most common cancer. The next slide, Kiranji. It's a 7 most common cancer in males and 10th in both the genders together. Age standardized incidence rate per 100,000 population is about 9.5 and 2.4. It's a slowly growing incidence, which we have to admit because of the high prevalence of smoking and industrial exposure of chemicals. And nearly 3/4 of them are non-muscle invasive cancers that majority of us know. Let's move to the next slide. That's for the staging, which next slide, please, Kiran. So the staging is all of us know. The most important thing here is nodal staging. So I would want to bring this to the highlight that single node is N1, multiple nodes in the true pelvis will be N2, and common iliac will be labeled as N3. So we tend to forget about this particular thing. Prostate, we do not have N1, N2, N3, but bladders, we generally demarcate these for our decision making, and that helps for taking decisions on lymphadenectomy as well. The next one. Yeah, diagnostic evaluation. Will be taking a quick review on this, but why I've added PSA as a slide, because majority of the time we know that on the radical prostatectomy, cystoprostatectomy specimen, we have early prostate cancers. So this will be an eye-opener percentage. Nearly 21 to 50% indolent cancers will be detected. So approximately 1/5 of the reports in universal combination on cystoprostatectomy will have potentially early prostate cancers, which are obviously very indolent diseases. That's why it doesn't have a clinical significance. And here we are dealing with two cancers wherein bladder predominates in terms of biology. So it is not of a major significance, but it is a definitely a good move to examine your patients for prostate evaluation by doing a quick DRE and adding a PSA test as a part of completion of workup before they undergo a cystoprostatectomy. Next one. Yeah, so about the diagnostic evaluations, MRI, all of us know that MRI comes very handy. A lot of robust discussion going on about pyrites, and similarly virites has been discussed on multiple scenarios at this point of time. It's relatively an underexplored field, being very honest. Not the radiologists also have very large experience of that, but still a multi-parametric MRI for MRI virites acquisition and scoring has a high predicting pool sensitivity and specificity of about 0.83 and 0.90, which is a very high percentage number. And both CT and MRI may be used for assessment of local invasion by T3B disease or higher, but they are unable to accurately diagnose perivesical. So we are trying to explore that predominantly for T2 versus T3A evaluation. The next slide. So a nice paper, which is a review, which told us, next slide, please, Kiranji. Yeah, so the nice paper, which told us a differentiation between what are we achieving from MRI? So basically T1 versus T2 combination, that is for possibly skipping the restaging TURBTs. Second question, which people are trying to answer out of MRI, is T2 versus T3, in which they are trying to embark upon upfront neoadjuvant chemo versus upfront surgery. That's a debate which they are going to solve. And potentially T4B versus T4B clinically less than T4B versus T4B, wherein the decision of operative yes or no has to be taken. So everything has been potentially sequentially taken into account. And MRI is coming in handy for evaluation of T2 versus T3. We are not in a position to differentiate between T1 versus T2 at this point of time. So a role of restaging TURBT does not change. But being very honest with you, there is a recent literature on a paper called, there was a trial called Bladder Path, which was recently published this year. Actually, it's going to be discussed in another forum on the weekend. But that is a trial which is trying to potentially embark upon skipping the histopathology and assimilating cytology and MRI for diagnostic workup. So what I would say at this point of time for resident learning, things are evolving. Let's not say that MRI will skip the biology or pathology. A procedure of TURBT and examination is must. But MRI would come handy for differentiation for clinical purposes. It would come handy for discrimination of T2 versus T3 disease, for deciding whether we can explore neoadjuvant chemotherapy versus adjuvant chemotherapy. I'm restricting my thing to MIBC, but still that's the thing. On nodal staging, next slide, please. On the nodal staging, low sensitivity for detection of lymph node metastasis and low specificity in general. So any imaging will give you adequate information on nodal staging, but we have to take it with a pinch of salt, because majority of the times these nodes are elongated and enlarged. So all of us know, just to reiterate, which nodes are significant. So size specific criteria will be more than 1 centimeter, and more importantly, a loss of fatty hilum, which a radiologist will be in a position to tell you whether there is any important finding of that sort, plus a short axis and a long axis. So all of us know that once the nodes are involved, the nodes become more roundish than elongated. So whenever you see those kind of nodes in the obturator fossa, in the iliac group, you should be in a position to suspect these nodes. So pelvic nodes, they say 8 millimeters, and abdominal node, they say 10 millimeters as the criteria, but that is for short axis. So always remember, it's not the long axis. A more elongated node, in fact, I'm potentially not very suspicious for that node, but longer the axis of a short, more the dimension of the short axis, we should be more suspicious of that node. Another important thing here is upper tract imaging. So all of us know that a CT urography will come handy here. We have nearly more than 11% chance of having upper tract TCC in the same setting. A CT comes handy, but sensitivity and specificity. Specificity is quite adequate. Sensitivity stays little on a lower side. A large variations do happen. More importantly, please do not forget about CT thorax for estimating completing the workup. So again, an exam question, as we are discussing with the residents today, I'll try and have some practical questions which generally the examiners are tuned to ask. So they will obviously ask about the role of PET scan. So potentially, I would say for exam purposes, don't rush into doing PET scans. A standard CT thorax and CT abdomen should complete your workup. Preferably, you should not. It's an examiner who tries to ask you whether PET scan will be necessary or not, and you tend to in a flow you tend to say yes, and then the examiner probably would question that. So try and stick to basics. A CT thorax and CT abdomen as a part of guidelines should be adequate, but don't forget about CT chest. So what I would say is that is not just true for bladder cancer, but any exam vivas. What I would say is always ask this question in your mind before you start going towards diagnostic steps or therapeutic steps, that have we completed the workup as a part of diagnosis? Have we completed the metastatic workup, especially in a malignancy case? So, and in that, if you ask this question, you would not forget about CT thorax anytime whenever it is necessary. So CT thorax obviously will come handy for all except for prostate cancer. So CT thorax will be a part of evaluation of kidney cancers, upper tract TCCs, bladder cancers. So that we have to remember. And potentially for testicular tumors where there is a node in the retroperitoneum. Next slide, please. So that's the EU recommendation. Muscle invasive cancer, so CT completion of CT thorax is necessary. CT urography is going to be important. Suppose if the creatinine is high, then potentially you can have a debate about having an MRI screening of the kidneys or not. That's a part of discussion. You do not always need to give contrast while doing an MRI. MR urogram with urine as the background medium can give you some adequate information about the filling defect. So that can be explored for completion's sake. And MRI will be coming handy for with WIRADs for demarcation of T2 versus T3 in the clinical exam scenario. Next slide, please. So important thing is age of a patient in your decision making. Chronological age has limited relevance. It clearly says in the EIU guidelines that octogenarians, we should not be hesitating in recommending a cystectomy if they are fit enough. So don't change your decisions based on age, but important is his performance status. So it is very important for you to summarize an ECOG grading of a patient or performance status of a patient. And there is a comprehensive geriatric assessment score also. But sometimes in an exam purposes, in the heat of moment, I think we can stick to basic of ECOG. If you tell this to the examiner that my patient is ECOG 0 or ECOG 1, examiner knows that you're giving some cognizance for the fitness for your decision making. That is very important. And that is what examiners are trying to embark upon. Based on the decisions of bladder sparing treatment, cystectomy in older frail patients of invasive cancer, tumor stage, and fertility. So all these things come into account, and Carlson comorbidity index and ASA grading is also important for your decision making. Next slide, please. So let's come to the discussion of neoadjuvant chemotherapy versus adjuvant chemotherapy. There is a graph which is seen on the right upper corner. So if I can take you through that particular graph, it was there in our surgical training, Love Bailey diagram. It tells you that before there is an exponential early growth pattern in the beginning, then there is a clinical diagnostic stage, and then there is a plateau phase of any given cancer, and ultimately it goes to lethal burden. So what I mean by this particular graph, that is called as Gompedzian curve, or there is a hypothesis called Norton-Simon hypothesis. So what we essentially would want to say out of this is, when there is a time of clinical diagnosis, majority growth of a tumor has already happened. So in an aggressive tumor, you may have to presume that there are microscopic cells or micrometastatic disease. Even if it is low burden, it does exist. So what we are trying to achieve out of neoadjuvant chemotherapies, we are trying to target that micrometastatic disease in time. That will also help us for testing of in vivo chemosensitivity. It will also have tolerability for chemotherapy, and patient compliance will be a little better because patient is not gone through a major surgery and he is not recovering through a major insult. So patients do tolerate it better. Favorable pathology, if you have a better response on chemotherapy, your fantastic pathology would be YPT0. Always remember that a designation of a pathology post chemotherapy or post therapy will be labeled as YPT. So YPT0 is one of the best possible reports one can ever get, and that has definitely a survival advantage. Your chance of margin negativity is increased in an aggressive disease. Overall survival, ABC meta-analysis has clearly told us that overall survival is 5 to 8% extra with neoadjuvant chemotherapy. No comparison on outcome of morbidity. So it does not also add to excess surgical morbidity. So what we are achieving is we are giving some better overall survival advantage. Simultaneously, we are not compromising on complications, and those are equal and based on Nordic trial. So please remember ABC meta-analysis, Nordic trial for quoting in the examination. They are all potentially quotable studies in the exam purposes. Potential negative sides, cystectomy might be delayed. So a patient who is not very sensitive for chemo maybe potentially have a problem, but that is a small domain. And clinical staging is only accurate for 70% time. So like I said, T2 versus T3. So it's still a debate. You can't really expect whether it is always a T2 or T3 disease based on only imaging. MRI will come handy, but there can be potential upstaging or downstaging. So you also have to sit down with your radiologist and discuss in the tumor board, see what your medical oncologist would want, and then take things forward. Neoadjuvant chemotherapy, patients with bladder cancer who achieve pathologically complete response, that which means absence of disease in the final path, have better OS and recurrence-free survival than patients who do not have pathologically complete response. That rate of YPT0 is variable. A rough percentage which we can quote is 28%, but again, I will say it is a little overestimated percentage. Yeah, probably 1/5 of the patients after tolerating the proper 4 cycles of gemcitabine and cisplatin will have YPT0 status of about 25 to 28%, and relative risk of OS is 0.45 and 0.19. So a number needed to treat by giving neoadjuvant chemotherapy to prevent one death is 3.7. So that these are the few numbers which you can quote in the particular study. About the immunotherapy, pure study, phase 2 study gave us some positive promising results. YPT0 status in pure study was about 42%. So that is nearly more, almost 12 to 15% more than a standard chemotherapy, but that is more into PDL1 positive patients with high TMB values. Updated results, promising response for variant cytologies also, typically squamous and lymphoepithelioma like cancers. That is what people are embarking now. Next slide, please. Kiranji, next slide. Yeah, the next slide. I finished the slide. Next one. Adjuvant chemotherapy. Yeah, the next one. About the adjuvant chemotherapy. Next, please. The next one after this, adjuvant chemotherapy. Yeah. So adjuvant chemotherapy, again, pros are chemotherapy is administered after accurate pathological staging. So you know whether it is pathologically T3 or not, or it just was limited to T2, whether node was positive or not, because all nodes which are potentially questionable on imaging may not be pathologically positive. So this is how we are looking into the details. Over treatment of a patient with low risk of micrometastasis is avoided. So sometimes you are just assuming that there will be micrometastasis. So you are ultimately delaying your primary surgery and doing a surgery for micrometastatic disease. No delay in definitive surgery. So these are the advantages of adjuvant. Cons will be, again, that patient assessment of in vivo sensitivity is not going to be possible, and there will be a potential delay in giving adjuvant chemotherapy because of the virtue of having positive or because of the virtue of complications and undergoing a major surgery. Next one, please. So for adjuvant therapy, a problem statement is a level of evidence is still very low with significant heterogeneity and methodological flaws in only few trials. So adjuvant platinum-based therapy, as of now, the guidelines would say that T3, T4 and lymph node positive disease would be subjected for adjuvant chemotherapies. T3, T4 positive disease and node positive disease. So for example, again, let's come next slide. Let's discuss about next slide, and then let's come to practical points. So OS pooled hazard ratio across 9 studies is about 0.77. That's the forest plot which is there in front of us. The next slide. And DFS is about 0.66. That is cisplatin based chemotherapy. And there is a 34% relative decrease in the risk of disease recurrence. So what is the guideline statement? Next slide. It says offer adjuvant chemotherapy for cisplatin based combinations in T3, T4 positive patients or N plus patients if neoadjuvant is not being considered. Only offer immunotherapy with checkpoint inhibitor in clinical trial settings. So now what is happening is currently the role of these particular things are evolving. What I would say, there have been few amendments and the trials which came after that. Let's simplify it for example purposes. What I would suggest is, if you have any dilemma about the imaging, potentially if you think that there is some extravesical haziness in the fatty tissue, do not hesitate in recommending neoadjuvant chemotherapy. Because for T2 diseases as well, what medical oncologists do, if they feel that it is very early T2, they will allow us for operative immediately in the tumor board discussions. But if it is a frank T2, a frank muscle invasion, a broad-based lesion with some haziness around the fat, then preferably that patient should be subjected for neoadjuvant. Because like I said, two reasons: there is no robust data on adjuvant side. Neoadjuvant has a strong role and survival advantage. So you will not commit mistake in exam if you commit, or if you tell about, or if you keep a low threshold about recommending neoadjuvant chemotherapy. That will give you a proper justification, or it will help you to justify your decisions well, and then potentially post chemotherapy patient will be subjected. Again, cisplatin based combination is important. Earlier they started with MVAC, then there was an era of dose-dense MVAC. The dose-dense MVAC has been revisited these days, so you should be knowing about all these chemotherapy regimens. Let's not go into details of it. It's not a scope of this topic. It's an overview which I want to give it to you. So remember about MVAC, dose-based MVAC, and a standard GC regimen. Again, GC regimen came into picture for neoadjuvant by extrapolating a data from adjuvant setting. And GC is a relatively well-tolerated regimen. That's why it has been recommended. You should be knowing about cisplatin ineligibility. So in an EAU guidelines, I should have taken that into account here. Figure should have been there. I'll amend it in the next presentation. But EAU guidelines will give you a proper figure about how you call patient with cisplatin eligible. So for that, you need a GFR of more than 60. 4 parameters are taken into account: performance status, cardiac risk, or the cardiac factors by doing 2D echoes and NYHA classifications, your the nerve conduction studies, and most importantly, the creatinine and eGFR, if it should be more than 60. For patients with compromised GFR between 60 to 30, there is a regimen called split dose cisplatin. But preferably, the medical oncologists are not very keen on giving it, but theoretically, you should be knowing it. You reduce the dose from 70 to 35 and split the dose on 2 different occasions. That's why you minimize the toxicity. Cisplatin, if cisplatin is ineligible, giving carboplatin and gemcitabine will be inferior. So typically, an exam scenario, you have a hydronephrosis of a kidney and a creatinine of borderline 1.5. So in such a situations, if possible, try and calculate your eGFR before you actually start your VIVA. I know it's difficult to calculate, but in case, if at least if you are not able to do it, what I would suggest is when you are answering in the exam, discuss that with the examiner that I will calculate my eGFR if by Cockcroft Gault or CKD API, or by even handing it over to a medical long team, because they are the better people to calculate these. Once you calculate that, potentially you would say that I would potentially see whether my patient is cisplatin eligible with a GFR of being more than 60. For exam purposes, let's stick to 60 because they're not going to probe you for split dose cisplatin. Probably a straightforward case to you will be cisplatin eligible based on GFR of more than 60. If it is yes, keep a low threshold for saying neoadjuvant chemotherapy. If it is higher, I would say in that particular context, giving carboplatin will be inferior, and you are justified in operating the patients upfront, because that has been discussed on multiple forums on various panel discussions, that putting in stents or putting in external tubes majority of the times leads to problems. The external PCNs would slip off in the middle of a surgery, in the middle of a chemotherapy, and you will have a problem. So even in TMH or in majority onco setups, if patient is not eligible for cisplatin, they are generally subjected for upfront surgery. But take the flow as per what the examiner would want out of you from the examination. I have given you some perspective on this. Next slide, please. About bladder preservation. Another thing which I missed out on this year is there. We all of us know that the nivolumab therapy has been utilized now for adjuvant immunotherapy, though there are only few reports and variable literature of being having positivity on certain immunotherapy drugs and not having positivity on another few drugs. So variable results, but nivolumab is showing decent outcomes. So, and that is translating into disease specific survival, not majoritarily overall survival. And if you see the trial, the checkmate trial we are talking about, if you see the trial, the majority patients are bladder patients and few patients are upper tract TCC combinations. So if the patient is affording, you have T3, T4 disease and N0 and N plus disease, you are justified in recommending immunotherapy. But again, you probably a suitable way in answering this thing in the examination is that if you have not embarked upon neoadjuvant chemotherapy, then potentially you will think of giving adjuvant chemotherapy bar immunotherapy based on what your medical oncologist prefers, based on cosmetics and patient fitness. Another important thing which I would add here is if we have completed the neoadjuvant chemotherapy and the disease is out, the histopathology shows positive outcomes in terms of T3 disease. Giving more chemotherapies is not going to be a choice. This has been discussed with medical oncologists multiple times, that if you have completed 4 cycles of chemo, giving more adjuvant chemos is not going to help. In that particular context, there is a trial called BAR trial, which is coming from TMH, which has shown some decent outcomes. It's an ongoing trial, but the primitive results are showing some positive results, and there is some retrospective data, and European guidelines have amended it that at least for now it's not the level 1 recommendation, but a little inferior level of recommendation, which is telling you that adjuvant radiation can be explored for patients with positive nodes and positive T3 T4 outcomes post surgery and post neoadjuvant chemotherapy. So always remember about potential adjuvant radiation as a part of discussion. You have to understand that everything will boil down to patient fitness. Next slide, please. Bladder. Yeah. So keep this slide on. So bladder preservation, earlier one, sorry. Kiranji, earlier one. So bladder preservation, no direct randomization which will compare these two. Definitely no for monotherapy, that you need to know. Please, if it has to be a combination. So a trimodality is always superior to radiation as a monotherapy. Most importantly, a radical TURBT has to happen. The dose, there are variable schedules. So one thing which you can remember is bladder and limited pelvic nodes of initial dose of 40 to 45 gray, and a boost to the whole bladder of about 50, 54, and tumor boost of about 60, 60. So totally they go up to 60, 66 for the tumor boost. Sometimes they might hypofractionate in 20 fractions. Next slide. Again, patient has to be eligible for cisplatin based combination, or non-cisplatin is 5-fluorouracil, mitomycin, and gemcitabine. The survival outcomes are variable, 50 to 80, large variation. So you can't pinpoint the particular number, and OS advantage is about 30 to 70%. Always remember about salvage cystectomy rates, 10 to 30%. So how do you take this decision? Next slide. So again, another thing which is, next slide, please, Kiranji. Hello, next slide, please. Yeah, so National Cancer Database, 2004 to 13, which gave you a large data set of about 1,700 patients on TMT side and 6,000 patients on RC side. 2 years onwards, there was a significant and persistent higher mortality on TMT side. Again, this is a retrospective analysis, so you can't infer a lot of things out of this. And 3 years onwards, that risk of having inferior outcomes on TMT or bladder preservations where the hazard ratio was 1.5. So longer the follow-up, cystectomy is going to be better. But let's not get biased because of that. Another study of large 20,000 cystectomies and EBRTs of about 2.5, and monotherapy and TMT of 1,400. So survival after modeling was significantly better for RC compared to any EBRT or definitive EBRT and TMT. So there are certain reports in favor of TMT also. For exam purposes, next slide. Suitable candidate for bladder preservation, I would say, is, remember these 2-3 words. Let's keep it simple for exams. Solitary tumors. So if you have multiple tumors, probably I would not go in favor of TMT. It's a solitary tumor, node negative, definitely node negative individual. No extensive, and obviously a gross extravesical extension also is going to be a big no for trimodality therapy. No extensive multifocal CIS. So always look into your pathology, not just only T2 disease, but whether there is any CIS concomitant along with your T2 disease. That candidate is not going to be for bladder preservation. And no tumor related hydronephrosis, and good pre-treatment bladder function. So bladder capacity should be adequate. So that's a very select group of patients wherein a TMT can be explored. People have started utilizing more often for these indications or little extended indications beyond this, which are summarized here in the figure. But for exam purposes, let's keep it simple. A lesion which can be potentially completely resected by a radical TURBT, potentially a single lesion, no hydronephrosis, no CIS, no gross extravesical disease or node positivity, and good bladder function. This is my ideal candidate for trimodality therapy. Offer surgical intervention or trimodality preservation to appropriate candidates as the primary curative therapeutic approaches, since they are more effective than radiotherapy alone. So no single therapy, it has to be a combination. And these chemotherapies are radiosensitizing chemotherapies, that you have to remember. So they are concomitant. They are not one after the other. They are simultaneous. offer TMT as an alternative to selected well-informed compliant patients, especially whom cystectomy is not option or acceptable. Next slide. Timing radicals. Let's come to radical cystectomy. So after 12 weeks, so 3 months, after 3 months of diagnosis, your potential outcomes are going to be bad. So anyways, we don't wait for 3 months, but for exam purposes, try and mention that I have to do the cystectomy earlier. I'm not covering early cystectomy. Keval will log in most likely again, and then he'll be able to discuss about early cystectomy. But this is for T2 diseases. So standard resections, we all know bladder, prostate, seminal vesicles, distal ureters, and regional lymph nodes. We tend to send frozen sections of the ureters in case there is any hydronephrosis. And the final margin of the ureters will obviously go for a complete evaluation as well. In women, it's an anterior exenteration along with the regional lymph nodes. So about the lymph nodes, next slide. Standard lymph nodes, cranially, common iliac bifurcation, ureters being on the medial border, lateral borders are genitofemoral nerves or the wall, caudally the lacunar ligament, lymph node of Cloquet, and internal iliac, presacral, obturator fossa, and external iliac nodes are covered. So that's a standard template. You just remember one thing, in extended, what you do is you take out common iliac nodes and presacral nodes to the core, and go to the level of aortic bifurcation. Super extended is you go to one level above the aortic bifurcation till the level of inferior mesenteric artery. What we conventionally do, or for exam purposes, you should be answering is extended lymph node dissection. Next slide, please. So lymph node optimal extent of lymph node dissection has not been established clearly. That's as per AU 21, and that stands true for these new amended version also. But extended lymph node dissection might have therapeutic benefit compared to less extensive dissections. So important is a template-based discussion, not nodes are the count is important. There was a lot of variable literature. Sometimes there is a paper about having at least 14 as a minimum count. Some papers showing 21 and 23 as the count. More definitively that more the count, beyond certain count, the overall outcomes are not going to be improving a lot. So what I would say for example purposes, you should answer that I would do a template based extended pelvic lymph node dissection. The prognostic sign is your the number of nodes and lymph node density as one of the important things. Let's talk about stage migration. So Will-Rogers phenomenon. One nice example, I remember this when I was a urology trainee in Sion Hospital. There was I forgot the faculty who had come to Hyderabad Reddy's campus for that USI teaching activity, which we used to have that time. So he gave me a nice, or he gave us a nice overview, that a simplified exam purpose explanation, that how do you understand, what do you mean by stage migration or Will-Rogers phenomenon? That what is happening is ultimately you are trying to do extended lymph node dissections. So thereby what is happening is you are having apparently better survival on both sides. So before I explain it to you again, I'll give you a quick example. Currently the IPL is going on. It's a good time to give this example. You have an Indian cricket team. I'm deviating from a very clinical aspect to a little practical aspect, but that's important. Everyone will probably remember after this. So there is an Indian cricket team. There is a IPL cricket team. There will be 10 players. A 10th player on the batting side, on Indian side, will be the inferior most player on that order, but he'll be relatively better if you compare that with IPL team. So if you take out a 10th player from Indian team and put it into IPL team, the average importance or average scoring of both the teams will be better. So this is what is happening in stage migration, that a patient who was ideally labeled as, or who would have been ideally labeled as N2 or who would have been labeled as N1, because of the extended dissection is going to be labeled as N2. So eventually we know that N2 will have a little inferior prognosis, but that patient would have not been detected and he would have biased the outcomes if he would have been kept in N1 domain only. So as he was picked up from N1 into N2 cohort, the apparent survival of N1 cohort increased. Likewise, a badly N3 disease will be labeled as N2 if we do not do an extended dissection. So on both sides, the apparent survival is going to be better. So that is what is stage migration means. Next slide, please, Kiranji. Yeah, so radical cystectomy type. Let's not go to robotic approach for exam purposes. For exams, please say a conventional open radical cystoprostatectomy or anterior exenteration in females. Just you should be aware that robotic platform does exist. It is more of a non-inferiority trial as compared to ORC, a razor trial, and there is a recent publication of IROC. In Razor trial, it was open divergence with robotic cystectomy. In IROC, it's all robotic cystectomy and conduit or neobladders. The progression-free survivals are similar, adverse events are similar, quality of outcomes are similar. Only thing which happens is robot takes more time and more cost, but a shorter hospital stay and less of blood loss. Overall, major complications are going to be same, so that you have to remember. Next slide. So do not indulge into asking robotic approach when you have not seen it in examination. Stay as basic as possible in exams. That would be more appreciated with the examiners. Next slide, please. So again, the similar outcomes. I was one of the authors of this particular paper. Let's skip this. A large data set where there is a distinct difference between the overall outcomes in terms of length of stay. Next one, urinary diversion. How do you? One slide back. So urinary diversion, well-informed decision. Kiranji, one slide back. Yeah. So urinary diversion, well-informed decision about the type of diversion, less decision regret post and operatively. So what I would say is in exam purposes, counsel the patient well, or at least in front of the examiner, you have to mention that I would want to sit down with the patient, talk to him about the aspects of conduit and neobladder. 2-3 important things which you should be knowing is that younger the patient, neobladder is more favorable. So there is no fixed cutoff, but generally in clinical practice, what we say is about 60. Less than 60, you can potentially consider. Beyond 60, majority will say in way of conduit, and you can very well say that in exam purposes. Preferably, why I'm saying this is because you have seen conduit at least multiple times. You have not seen neobladders to that frequent times. You have not seen the management of the neobladder perioperatively that often. So try and stick to what you have seen. You are justified in saying conduit if you're well tuned to managing that conduit related complications perioperatively. An examiner would want to see whether this particular candidate is a safe candidate after he completes his MCH or DNB. So contraindications for neobladder, invasive urethral tumors, and again the tumor involving the prostatic fossa near the apical margin positivity. Earlier they used to say that node positive disease neobladder is not a very good recommendation, but for N1, that is up to 1 node in the pelvis, they can say yes to it. But again, like I said, until you wait for final pathology, you are not going to find. So in clinical practice, in your exam purposes, I would say a node positive disease, first of all, should be going for neoadjuvant chemo, and I would potentially be going in favor of conduit rather than neobladder. Theoretically, for N1 diseases, you can do neobladders, but that is only after the pathological examination, which is not going to be happening intraoperatively. N2 and N3, preferably it is not recommended. Oncological results after orthotopic neobladder substitution or conduit are similar. So oncological outcomes are not going to be changing. One thing which you have to tell it to the patient that if there is a potential problem in the urethra, because patients of neobladder would need to do clean intermittent catheterization for emptying their bladders. Secondly, if the patient is ready for nocturnal incontinence, whether the patient has an easy access for medical emergencies. If patient is not staying in a remote location, I would go in a side of conduit diversion. So all these things would come into picture for your decision making. So try and not stick to one particular thing in your mind. Try and consider a patient as the whole unit for whom you have to take a decision about your perioperative outcome. So decide about the whole thing after you go through the entire history about his urethral status, about his willingness to do CIC, feasibility for doing a CIC, access for a medical setup, and potentially acceptance of nocturnal incontinence for the patients of neobladder. And most importantly, an educational status of the patient. If patient is not compliant, probably you would straight away go for conduit. So no shame in saying conduit as a diversion of choice in examination, because you're more tuned to it. Believe me, nothing will go wrong if you stick to one thing and defend it in examinations. Again, the divergence, they are getting picked up. Robotic approach is getting picked up routinely. And a flip side of that is conduits are getting more in number than neobladders, but that's not for exam purposes. More importantly, volume effect. So high volume centers, less complications with, next slide, please. Yeah. Next slide, Kiranji, then the next one. High volume centers, less major complications after intracorporeal reconstruction as compared to extracorporeal. Clavin window, always remember you have to mention it to the relatives and the patient that Clavin window complications of grade 3 and more are almost 16 and 20%. And 90-day mortality and major complication rates need to be discussed. A high volume center by definition is more than 10 RCs per year per hospital. And per hospital is preferred is more than 20, but it should be per year per hospital, 10 surgeries. This is what we should be doing. The next one, So ERAS, quickly you should be knowing that both another one more slide in this. Kiranji, one more, if you can place one more, but yeah. So ERAS Society has given good recommendation on particularly the bladder cancer. Please read these two papers. They are very nice. One is for robotic approach, one is for in general cystectomy. They've given nice 23 parameters of ERAS, which are elaborated on the next slide. Next slide, please. So it goes from preoperative counseling to Kiranji, next slide. It goes from preoperative counseling till the perioperative care. So this is how we follow the ERAS protocols for our patients. Important things out of which you should be knowing is carbohydrate loading prior, minimization of smoking, nice and proper counseling perioperatively. These are the 2-3 important preoperative parameters. Intraoperatively avoid excess of fluid overload. Try and minimize your surgical time. If it is robotic approach, that will definitely help in terms of minimization of evaporations, ureteric handling. So minimal invasive approach is going to be recommended for ERAS at least. Immediately perioperatively, early feeding, early mobilization, thromboprophylaxis. Another thing is allowance for carbohydrate loading, which we discussed, and these are maltodextrin. These are medium chain triglyceride, medium chain ones, and that will help to I mean to say the maltodextrins, which are easier for digestions, and those will have impact on the insulin sensitivity, and that's the reason why these have better impact. Another thing is consistent surgical team, prevention of perioperative nausea, vomiting. Albumopan, you should be knowing theoretically, it's not available in India, but chewing gums and mobilizing patients are important for bowel motility, and most importantly, your audit of your outcomes. That is what is important. Next line, morbidity of cystectomy. You should be knowing about percentages of 30-day and 90-day mortalities as well, which are quoted to the range of 1 to 3 and 2 to 8%. Let's not speculate about this in exam scenarios, or let's not get worried about this, but a thorough counseling is mandatory, and that you need to re-embark when you're making a plan of cystectomy. Typically, a Clemidindo grade has been modified for bladder cancers. It's been available in EAU website. Please go through that. Next slide, about the variant histology. Muscle invasive pure squamous cell cancer of bladder should be treated with cystectomy. So pure squamous, unfortunately, they are not responders. Adenocarcinomas are also not that great responders. They should be treated. Pure adenocarcinoma, again, cystectomy. Micropapillary as a part of early, as a non-muscle invasive phase, again, is a candidate for chemotherapy. The sarcomatid component, sarcomatid variations, and neuroendocrine variations are embarked with neoadjuvant chemotherapy. That you have to remember. But pure squamous, and another thing is there will be a confusion in the reporting that there is a urothelial cancer and there is a squamous proportion. So what do we need to do? Need to find out of the pathologies which is a predominant one. If it is squamous, which is predominant one, probably you would say that we should be giving what do you say, upfront surgery. And if it is the urothelial one, which is common or which is predominant, you should be saying in favor of chemotherapies first. So this is what the overall thing is. Follow-up, next slide. Follow-up is relatively straightforward. Always remember that whenever you have done a conduit and not done a urethrectomy, the follow-up of a urethra by putting a cystoscope as an urothroscopy is important. Indications of urethrectomy also theoretically you should be knowing. That is when you have a positive disease at the apex or a prostatic stroma is involved. These are the candidates where you would probably embark upon urethrectomy. It can be done at interval. It can be done at the same stage if you have a facility of frozen section. But try and stick to what you see on your routine practice at your center as a trainee. Don't try and things under imagination, and then the examiner will probably create problems for you. So try and stick to what you've seen. Tell the examiners that I would want to wait for the final path and then decide about urethrectomy based on the final histopathology report. Other follow-up would be in terms of evaluation of the abdomen for nodes, chest, and upper tract evaluations as well. A conduit cytology will also, or a neobladder voided cytology would come handy as well. And for bladder sparing or bladder, next slide, last slide, follow for post bladder sparing surgeries is going to be here your follow-up is going to be a little more stringent. A bladder preservation will mandate regular cystoscopy, regular surveillance. That will be important for you to decide what's the whether the disease is coming back. Because if the disease is coming back in high grade variation, preferably a recommendation should be salvage cystectomy. There is a debate about it. People are thinking that low grade recurrences post radiation are still can be salvaged but it's a potential debate. I would say, an example for this, any high grade recurrence post radiation or trimodality therapy where you have a lesion on the surveillance scopy and you resect the lesion, it's a high grade tumor, potentially a candidate for salvage cystectomy, and all of us would admit that the complication rates are going to be little higher because of the radiation effect on the lower ureters and the bowel, and then the anastomotic leak chance or the complications or strictures are going to be little higher, that we anyways counsel these patients upfront. So probably we tried to touch base on a majority aspect. I have not covered metastatic one because that's not a part of examination routinely. Read through the immunotherapies, read through the chemotherapies for metastatic spectrum, read through the PDL1 expressions. That will give you some scoring points. I think Keval, is he logged in? Kiranji?
Keval, are you there? Keval?
Keval?
Ashwin, can you call him and find out?
I'll just check, sir.
Hello. Hello.
Sir, he's not logged in with his name. So I'm not sure whether he's there.
Hello. Kiranji.
Keval, are you there?
Yeah, I'm there. I'm logged in some other device because
no problem. No problem. Can you open your presentation?
You can tell Kiran to just. Will you be able to load your presentation, upload your presentation from there?
yeah, sir. Let me first
or you
share.
can send it to Kiranji quickly on her email. She'll just send you the email ID. That will be easy. And
Okay, I'm trying to share. I'm trying to share my screen.
Yeah.
Is everyone able to see? Hello. Hello.
Not yet, sir.
Okay. So do you have my presentation, Kiranji?
Can you send it on an email, sir? We don't have it at present.
Okay. So tell me, yeah, I'll send it. Where should I send it?
You can send it to USI central office at gmail.com.
Yes. I'm doing that. USI, yeah. I've sent the mail, ma'am. Did you get the mail?
Not yet, sir.
It's from Dr. Keval Patel at @yahoo.com. Kiranji?
Not yet, sir.
Acha. Wait.
I have just received it, sir. I'll just put it up.
Okay, okay. Yeah, that's it. So we can go forward. We've already covered this.
Sure.
The next one. The next one. Next one. The next one. The next one. The next one. I think we covered second random biopsies also. Next one. Next one. Okay, so we were stuck at this. Unfortunately, I'm very sorry that I got logged out at very wrong time in between my presentation. But now let's us resume from where we left. So next step, which is very important, is that what you do when the tumors are not visualized and you still want to remove all the tumors. So you may be asked in your exam that what are the newer methods of tumor visualization. So the first one, which has been extensively studied is photodynamic diagnosis. That is intravesical instillation of 5-aminolevulinic acid or hexaminolevulinic acid. And then the cystoscopy is done using a violet light. Now, what would be the appearance? You know, if you quote this, the people like many people may not have these facilities in the centers, but at least you should know how they appear. So the normal tissue will appear purple and the tumor tissue will appear pink. So you can say that pink tumor against purple background will be very easy to pick up, and those can be the biopsies of those tissues can be done and additional tumors can be found. Next. Now, if we look at the literature, like what is the sensitivity and specificity of photodynamic diagnosis? So definitely as compared to white light, the sensitivity is more, and especially for carcinoma in situ, it is 93%. You should remember some percentages. It is 93% as compared to 65%. However, the specificity is low. That is, you can find false positive result in cases of inflammation, or whether in the patient has undergone recent TURB or post BCG cases. So you should keep in mind that photodynamic diagnosis has high sensitivity at the cost of lower specificity as compared to white light. If we talk about the impact on recurrence, like whether using this will decrease the recurrence, then yes, the decreased risk of recurrence and improved type 2 recurrence for at least for the first 2 years and possibly up to 4 years was found out in a recent systematic review. So you can say that it will decrease the risk of recurrence. Next slide, please. The second method, which has also been quoted in the guidelines, is a narrow band imaging. So what is it? In narrow band imaging, the contrast between the normal urothelium and hypervascular cancer tissue is enhanced. So it can lead to improved detection and decreased recurrence at least 1 year. However, all the studies or all the studies, they don't agree in this fact. And so you can always say the results are mixed for narrow band imaging. Next slide. Recent 2023 update of EAU guidelines have included Image1S and other technologies as the newer method of visualization of the tumor. So what is Image1S? It is available from Karl Storz. It's an image enhancement system based on computerized processing of different color components that use specific light filters to diagnose the tumor. Well, although the technology is there, but the evidence is very limited so far. And so it cannot be recommended for routine use. And another technology is a confocal laser microendoscopy. It is a high resolution imaging probe designed to provide endoscopic histological grading in real time, but requires further validation. So for the completion, sake of completion of the list, you should know these technologies. However, they are not very much established. Next slide, please. Now comes a very important topic, which usually or maybe examiners may embark upon in your exams, that what is relook TURB or what second TURB, in which indications you will do a relook TURBT, and what would be the timing and what is the rationale. So you should be very clear in your mind about relook TURBT and second TURB. The indications for a relook TUR or a second TUR are residual disease, like incomplete TURB has been done and the tumor has not been removed completely. In those cases, a second look TUR is always indicated. If although the complete TURBT has been done, but the muscle is not present in the initial biopsy, then a relook TUR is indicated. In all cases of T1G3, and why, that I'll explain in the rational section. The timing is usually within 2 to 6 weeks. So we have a comparative study here in which they compared doing a relook TURBT between 2 to 6 weeks as compared to 6 to 12 weeks. And they found out that significant decrease in recurrence-free survival and progression-free survival was seen when relook TURBT was done within 2 to 6 weeks. And that led for the guideline panel to adapt the timing of relook TURBT between 2 to 6 weeks. Now, rationale for doing a relook or second TURBT is that in any T1G3 specimen, there are at least 51, various studies have quoted various numbers. So there's not a single number, but at least 51 to 58% chances of a residual or persistent disease in T1. It can also happen in TA, but the chances are less. T1, they are more. And the residual or persistent disease is mostly found at the site of the previous tumor. Also, studies have shown that there is 8 to 11% of percentage of understaging in the primary biopsy report. So at least relook TUR is also indicated. Next slide, please. Yeah, some studies have also found improved survival, that is recurrence-free progression, and even OS after doing relook TUR. It also provides some very important prognostic information, and that is the reason relook TURBT should be done in all cases of T1G3 especially. Next slide, please. Now with this, TURBT has been done. You have reported it very adequately. The biopsy report has been achieved. Now what next? Now the further treatment of the patient depends on risk stratification of the patient. So you have to risk stratify. This is a very good table which I have adapted from the recent EAU guidelines. And it's a cumbersome and full of data. But how simply I remember it, that like a single primary TAG low grade tumor less than 3 centimeter without CS means all is negative. Age is also less than 70 years. That is a low risk. In high risk, all T1G3 and carcinoma in situ are included in very high risk. And in T1G3, but no carcinoma in situ, then there should be at least 3 risk factors. Now, additional risk factors based on the various studies EAU has recommended are age more than 70 years, multiple, usually more than 3 papillary tumors. They have not mentioned the number. In previous versions, it was there, but in this version, they have not mentioned the numbers, but it should be multiple papillary tumors. The tumor diameter should be more than 3 centimeter. So if all these 3 risk factors are present, it's a high grade tumor T1 and no CI is present, then it should be very high risk. High risk, how it is differ from very high risk, that in all grade 2 lesions are there except TA and high grade, and no carcinoma in situ is present, irrespective of the risk factors. This is how I remember what is high risk, very high risk, and low risk, and rest all the cases would be in intermediate risk group patients. So one more thing which EAU guidelines mention is that all the patients in which carcinoma in situ is present in posterior prostatic urethra, all subtypes of urothelial carcinoma, And the patients who are having lymphovascular invasion, they should be considered in a very high risk group because they have a very high risk of progression. So this risk group risk stratification is based on the risk of progression of the disease. And what are the percentage you should remember, which I have included in my slide at the end. So I'll come to that. But then you remember one thing, that this risk group are on the basis of progression of the disease, and based on that the management is decided. So once you remember this important slide and you risk stratify the patient, the next step would be management of the patient. Next slide, please. So what are the management strategies? So basically, any non-muscle invasive bladder cancer, so we basically or we deal with intravesical therapies. So first I look at chemotherapy, then the BCG. Lastly, indications for radical cystectomy, and then I'll end my talk. So intravesical therapy, a single immediate post-operative intravesical installation of chemotherapy. So what is the mechanism of action of that? It destroys all the circulating tumor cells. It has an ablative effect on residual tumor cells at the resection site. It has ablative effect on overlooked tumors. Sometimes we may miss tumors which are very small, and very small tumors may have ablative effect by intravesical installation of chemotherapy. What are the drugs used? Usually mitomycin, also epirubicin, gemcitabine, and the literature says that efficacy-wise all are equal. There is no major difference in between them. In a single installation will reduce 5-year recurrence from 59 to 45%. That is 14% absolute advantage in as far as recurrence-free survival is considered. Timing now, when should be done? So it should be done within 2 hours of TURP. Initially, like we used to study in previous version, it was 4, but in recent guidelines, they have updated to 2 hours. And what is the rationale for that? Because after 2 hours, the tumor cells will get form implanted at the resection site and may be covered by extracellular matrix, and which may not allow the chemotherapy to act. And so it should be given within 2 hours. Next slide, please. Now, that was for single post-operative immediate installation of chemotherapy. What about additional intravesical chemotherapy installations? So then again, as I told, depends on the prognosis, which we saw further in risk stratification. If it is low risk, the guidelines recommend that there are no further installations are required. If it is intermediate and high risk, the further installations are indicated. It will reduce 1-year recurrence by 13 to 40% and 3 years recurrence by 9%. So how frequently they are to be given? Usually they are given on monthly doses, and a maximum up to 12 months they can be given. The chemotherapy agent should be retained into the bladder for at least 1 to 2 hours. Next slide, please. However, intravesical chemotherapy installations is not devoid of any complications. Although the complications are less than the BCG, but still the patient can have chemical cystitis in 40% of the patients. If systemic absorption is there, then the patient can also develop myelosuppression. So these 2 complications you should keep in your mind. Next slide, please. Now I will come to intravesical therapy in the form of BCG. So, most of the times, even I don't know when I just passed out that what is the mechanism of action for BCG. So it creates local toxicity by either cell-mediated immune reaction or direct immune reaction. So it destroys the implanted cells or the cells at the site of the resection. Studies have found out that there is 32% reduction in the risk of recurrence for BCG as compared to chemotherapy alone. But they also say that if BCG is not given with maintenance, then there is 28% increase in risk of recurrence. So the point to be taken here is that BCG should always be, induction BCG should always be followed by maintenance BCG. Also, in various studies, the BCG is only drug which has found to delay and potentially lower the risk of tumor progression. So mind well here, the BCG can only delay progression, cannot prevent it totally. So there is absolute reduction of 27% in the odds of progression with BCG maintenance therapy. The size of reduction was similar in patients with T1 and carcinoma in situ. Next slide, please. So what is indication? What are the, like, how many doses are to be given in induction and maintenance? So for induction, it has been very well defined by Morales. Like instillation should be weekly for 6 weeks. And as a part of maintenance therapy, it should be given every weekly for 3 doses, every 3 monthly for 1 to 3 years. So now, when it should be given for 1 year, when it should be given for 3 years, that are also been defined in the guidelines. And the findings are based on the EORTC study, and in which they found that maintenance decreases recurrence in high risk, but not in intermediate risk. And there is no difference in progression. The timing. So when it should be given, it should be usually given 2 to 4 weeks after TUR. Like, you can be asked in exam, why not within 1 or immediately like chemotherapy? So BCG, if it is absorbed from raw surfaces, it can cause a very grave sepsis. I have seen patients who have become gone into septicemia because of the BCG. So it should always be given between 2 to 4 weeks after TURB. There are specific instructions which have to be followed while giving intravesical BCGs. Like, the drug has to be retained for at least 2 hours. There has to be frequent change of posture. The patient should be avoiding in sitting position, followed by flushing to avoid cross infections. Fluid, diuretic, and caffeine should be restricted. Next slide, please. Now, there has been lots of talk in various forums about the strains of BCG. Like, you should be knowing which strain is available in our country. But one thing is there, that any of the strain, as far as efficacy is concerned, the results are same. What is the optimal dose? 120 is the routine initially recommended dose. Then EORTC came up with a trial in which they found that there was, by decreasing the dose to 1/3 as compared to the full dose, the toxicity is same. Although toxicity is same, and there is increased risk of recurrence. So suppose the patient is of high risk, and if you give it for 1 year and only half dose, 1/3 dose, that there is toxicity is going to be the same, and in fact you are increases the chances of recurrence. A SWOG trial have shown that the recurrence-free survival has been increased after giving maintenance BCG as compared to only induction BCG. However, only 13% tolerated the 3-year maintenance dose. Sorry, 16% tolerated the 3-year maintenance dose. Next slide, please. Now, one common question which can be asked in all the exams and viva is that, what complications do you routinely see after giving BCG? So basically, you should remember that BCG can cause 2 kinds of side effects. One are at local level on the bladder and symptoms related to bladder or surrounding organs. Secondly, systemic, because of systemic absorption, that is systemic side effects. So what are the local side effects? Now, most important is cystitis. So the patient may have urgency, frequency, and dysuria. Most of the times it is self-limiting or can be controlled by giving simple NSAIDs or antibiotic in the form of either ofloxacin or levofloxacin. If they persist for more than 48 hours and are severe, you can always give AKT with steroids. Ultimately, radical cystectomy is going to answer. Hematuria, again, it is a very common symptom. Patient may come for 1 or 2 days after BCG installation. If it is mild, not bothersome, and self-limiting, I think we can do away with, or we can continue our BCG. If it is severe, you should get a culture done, give antibiotics, and sometimes cystoscopy may be needed to rule out additional or residual tumors. Very rarely, patient may present with granulomatous prostatitis and epididymoarchitis. Mostly the treatment is steroids and if quinolones, and if it is not been controlled by quinolones, then AKT in the form of isoniazid and rifampicin for 3 months is usually indicated. For epididymal orchitis, you can also always get away by doing an orchidectomy. Next slide, please. The systemic side effects of BCG. So, like many times you may find in your OPD that the patient after giving BCG comes up with fever on the very next day, and it's like high grade. So I think for fever of 1 or 2 days, less than 48 hours, you should treat them with antipyretics and like wait for the fever to go. Even general malaise. If it persists for more than 48 hours, then you should start with quinolones. Sometimes the patient may present with arthralgia or arthritis. Again, it is rare and the treatment is same, quinolones and steroids and AKD. Persistent high-grade fever, more than 100°F for more than 48 hours, I think that becomes an indication for stopping BCG. You should get additional tests in the form of blood test, cultures, urine cultures, chest X-ray to rule out distant spread. You should start antibiotics and not hesitant in giving AKT. ID consultation should be ideal in these situations. Very rarely you may find if the instillation has been done after the patient had hematuria or still persistent symptom and the patient goes into BCG sepsis. I think the BCG should be stopped. Steroids and AKT, 3-drug AKT should be given for 6 months. Next slide. So these are the this slide is very important because examiner may ask you that in which situations, if you are giving the patient is on regular BCG therapy, and in which situations you should avoid or not give BCGs. So these are the contraindications of BCG instillations. So what are the absolute contraindications? The patient who is an immunocompromised, immediately, as I told you, like at least you should wait for 2 to 4 weeks, sorry. So it immediately after TURB is an absolute contraindication. If the patient is having gross hematuria, so there is always a risk of intravasation of the BCG and leading to systemic spread, so it should be avoided. If the patient is having traumatic catheterization, because BCG may implant at these places. If the patient is having total incontinence because the patient will not be able to retain the agent, if there is past history of BCG sepsis, these are the absolute contraindications. What are the relative contraindications? UTI, because again, intravasation risk, you should treat the UTI, and then again, like if you miss 1 dose, it's okay, you can restart the BCG. If the patient is having liver disease, because if the BCG sepsis occurs, you cannot give INH. If the patient is already having a history of tuberculosis, so anytime in examination, you should, before giving BCG, you should ask for history of tuberculosis. Again, poor performance status and advanced age are relative contraindications. Next slide, please. Okay, so once we have discussed what are the intravesical therapies for non-muscle invasive bladder cancer, at one point of the time, you are going to face with a situation when these therapies will fail. Now, what you should do? So, if the patient is on a chemotherapy, like for intermediate risk, you have for some reason you have started chemotherapy, then it's very easy because BCG is beneficial. According to a recent systematic review, BCG is beneficial after chemotherapy. Now, the main question here is that what should be done if there is failure of BCG? So, first of all, to know what is the treatment of failure of BCG, you should know what is failure of BCG. So once you have started BCG failure, there are certain definitions which you should keep, or you should be very thorough in your mind, because you are likely to be asked these definitions. So failure of BCG, the first would be that in follow-up TURBs, you detect muscle invasion. So that is definitely a gross failure of BCG and definitely is to be treated by cystectomy. Suppose what is BCG refractory disease? So every time you give BCG, the follow-up cystoscopy is to be done at 3 months. So if at 3 months, there is persistent of disease, like previously it was T1 high grade and persistent of T1 high grade, then it is known as refractory. If it is T1 TA high grade, at 3 months again it is TA high grade, and second challenge of BCG can or induction BCG can be given, and then again repeat cystoscopy at 6 months shows TA high grade or carcinoma in situ. It should be labeled as BCG refractory. Then what is BCG unresponsive? So it is a part of BCG refractory disease, but in which the high grade recurrence at 6 months of adequate BCG is given. Now you should know, which is recently the recent guidelines have included the definition of adequate BCG. So if it is first induction, at least 5 out of 6 BCG doses has been given, then it is labeled as adequate BCG. In second induction, if it is 2 out of 6, and in maintenance, it is 2 out of 3. So if any one of this is achieved, then it is known as adequate BCG. Even after adequate BCG for 6 months, there is high grade recurrence, then it should be termed as BCG unresponsive. Again, for BCG refractory unresponsive, most of the times the treatment is cystectomy. BCG relapse, like if you have high grade disease and there is downstaging at 3 months, maybe it becomes low grade, or there is no tumor, and then at 6 months you get a high grade recurrence. Again, it is known as BCG relapse, and that should be treated well in advance with cystectomy. BCG intolerant, as the name suggests, severe side effects which prevent further BCG installations. So that these are the cases known as BCG intolerant cases. Next slide, please. Now, once intravesical therapy, its complications, its failure and indications is over, let us move to radical cystectomy. What are the indications of radical cystectomy in non-muscle invasive bladder cancer cases? So there are 2 terms which has been coined in the guidelines, which I think everyone should know. Number 1 is immediate radical cystectomy. The other term is early cystectomy. So as the name suggests, immediate cystectomy is the radical cystectomy which is offered to the patient without giving any intravesical therapy. So those cases would be immediate radical cystectomy, and usually it is done in cases like, as according to the risk stratification, those cases which have very high risk of progression. The other cases are early cystectomy, which is offered after failure of one of the other intravesical therapy. So what are the indications and rationale for immediate cystectomy? So why immediate cystectomy is advised in very high risk cases? Because like studies have found out that there is 27 to 51%. You should remember these percentages somehow. Some examiners have like a habit of asking this. So 27 to 51% of understaging of T1 has been found in various studies. Studies have also found progression to muscle invasion in follow-up of T1 disease, high-grade disease, and progressive MIBC, like the MIBC which has progressed from T1 to muscle invasion, have definite poor prognosis, then directly detected MIBC, like 5-year survival, disease-free survival is 80% in case of primary MIBC as compared to progressive MIBC. Early cystectomy is offered in cases of, as I discussed earlier, in cases of BCG unresponsive and BCG relapsing high-grade tumors. Next slide, please. Now, treatment based on the risk categories. So, as I told, that the risk categories are defined based on the chances of progression of the disease and follow-up. So, for intermediate disease, there is 7 to 8% chances of progression. For high risk, it is 14%, whereas in very high risk, it is 53 to 58% chance of progression if treated by other modalities or not treated. So, very high risk, immediate RC is the answer. For very low risk, TUR biopsy plus single instillation of chemotherapy can be done, and the patient can be kept on regular follow-up. For intermediate risk, TURB with a single instillation of chemotherapy plus induction BCG and maintenance at 3, 6, and 12 months up to 1 year. for high risk cases, TURB plus single installation plus induction BCG and maintenance for 3 years is indicated. So why this risk category has been defined, and EAU has been like very much skeptical in giving treatment based on the risk categories, and this should be followed. So with that, next slide, please. With that, I come to end of my presentation, and again thank everyone. Sorry for the disconnection which happened during my talk. Next slide, please. Thank you.
Yeah, well, if you can see the question in the chat box, there's one which is from, I think name is not there. Can you hear me?
Yes, sir, I can hear you.
Okay, the question is for N1, 2, and 3, neoadjuvant chemo and RC, this treatment of choice. Is a question mark. He is believing whether the classical indication of radical cystectomy is T2 to 4A and 0 of neoadjuvant. I think he must be asking about the indication of neoadjuvant, whether it should be in the T to 4A stage with N0 status. Your take on that?
Sir, so I think Ashwin can take up this question because he presented this.
Yeah.
Ashwin, do you want to take
Yeah.
this?
So basically, sir, for exam purposes, what I would say is ideally every candidate is for new. These days we are marking so what I would say it is an early T2 front, but preferably we have new for T2. We are moving towards more new because that is helping our patients little bit of increase in the complications by months. Anything which is T3 neoadjuvant chemotherapy for purposes. So there is a little bit of haziness on the whether there is a deeper.
Keval?
Yes, sir.
Yeah, I think he got disconnected while his network was unstable at first.
Yeah, so I'll take that question, sir. I'll take that question.
You take this question, and another question from this is from
Ankit Sachan. Yeah.
So single installation of chemotherapy even in high grade MIBC. So these are all students who want to have more clarity what they should be answering. You can give us the answer for the exam, but at the same time, for enhancing the knowledge, you can give your comments also how they should be in practice, also how they should be dealing with it.
Yeah, definitely, sir. So, like I'll take the first question for N1 to 3 neoadjuvant chemotherapy and RC is the treatment of choice. So, I think that for any nowadays, like at our institute, we practice is that any disease, like there is absolute advantage of 8%. So that definitely is a very a big percentage of advantage. So all cases of T2 should be given above T2 or above any N should be given neoadjuvant therapy, and they are not metastatic. They should be given neoadjuvant therapy. At 3 months, the response should be assessed, and then that should be followed by RC. So this is what we follow at our institute. I think I have answered it for that question. Secondly, is there a role of single installation in even high grade MIBC? So again, you never know just beforehand that this is high grade or low grade. So like practical approach would be for any cases, immediate single installation of intravesical mitomycin, that is 4 milligrams, what we usually do 4 milligram in 100 ml of NS within 2 hours, and then block the catheter once the hematuria is over. After that we give, and we block the catheter for at least 1 or 2 hours and open it up. So that is a standard practice for all cases. Once the biopsy report comes, you know whether it is high grade or low grade. Then depending on the situation and various indications, you can take up whether the patient should be given BCG or intravesical therapy or is a candidate for immediate cystectomy. So all cases, high grade, low grade, all cases are indication are candidates for single installation of high-grade MIBC. Lastly, indication of intravesical chemotherapy and schedule for intravesical MMC. So I already included this in my talk, that single installation has to be done in all cases. Personally, the cases in which the BCG is contraindicated and the patients are intermediate or low risk, in those cases, I explain the patient all the possibilities that this can decrease your recurrence but not your progression, and offer them like extended or repeated installations of chemotherapy. The standard schedule, according to me, is every monthly till 12 months. So this is what we routinely practice.
Yeah, Keval, I think I totally agree with you. But this is also a question asked, especially in the time of when we have a BCG shortage and all that, whether after single dose installation, if the patient is to be continued on intravesical mitomycin, what is the schedule, a monthly intravesical installation for 12 months?
Yes, sir. Yes, sir. Yes, sir.
I think, let me just check any more question which has come. No, there's no more question. As Ashwin is not there, then we can, I think one more question is there. That is from Dr. Joseph Philip Raj. Is there any difference in hyperthermic intravesical mitomycin versus normal?
So, yeah, definitely there is a hyperthermic difference between hyperthermic and normal mitomycin installations. And I told initial part of the talk that some of the topics, like I have not included because that could go out of the scope of this talk and time. But yes, so electromotive or hyperthermic installations have there are lots and lots of studies for increasing the efficacy of hypothermic, but in routine, like most of the institutions in our country, we don't have that, and that is why we don't talk about it much. But definitely it helps better than routine MMC installation.
Yeah. So this hyperthermic, you keep it for BCG.
One more point to this, sir. There is a recent negative trial which came for hyperthermic mitomycin against comparison to other conventional modalities, which did not show very strong positive results. It's a recent last 2022 publication. So with that, probably the role of hyperthermic chemotherapy, hypothermic mitomycin or chemotherapy is going to be.
Yeah. So Ashwin,
it's a variable literature. Based on one trial, we can't.
The question is whether this treatment is kept. You reserve it for BCG refractory, or you keep it in the primary setting only. Adjuvant treatment.
So it will be primary. BCG refractory diseases, preferably a cystectomy should be the choice. Only for patients who are not in a position to be offered cystectomy, other options of chemotherapy or something. Even gemcitabine docetaxel is another new thing which is coming up. Residents should be aware of gemcitabine and cisplatin combinations and their dosages, which are generally explored as a part of chemo.
Sequential therapy, yes.
Yeah, I think, yeah, there's no more question. You have covered about gemcitabine also, and the different type of other combination available in the background of BCG refractory. With this, if there's no more question, with a lot of thanks and gratitude on behalf of Indian School of Urology to you both, you have covered it very nicely. I think for the residents, this webinar will be available tomorrow onwards from our USI YouTube channel. So you can refer it again for the sake of revision and during your preparations for examination. Very nicely covered, very erudite presentation from both the faculty. On behalf of Indian School of Urology, thanks to Keval, thanks to Ashwin, and thanks to all the agents who logged in. Thanks to Navneet and Kiran for the this. We sign off and good night, everybody.
Thank you so much.
Sir. Thank you.